How's it going, guys? So this is my second microbiology presentation for YouTube. We are going to just focus on the high yield points that will increase your score for USMLE. This will not be a long, meandering School of Medicine type of presentation with information that will not increase your score. That's not what we're doing here, okay? Just the high yield points you need to know for the exam. Before we get started, I will be my typical asshole, tell you to subscribe to my channel. I really appreciate it. Hit the like button. Hit the bell if you want notifications. Find me on Instagram at Melman_medical, MEHLMAN_medical. Link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the fucking presentation here where we have our gram-positive rods. It's to my observation that when students have an issue remembering whether an organism is gram-positive, gram-negative, rod, or coccus, it's because they don't have a visual representation of the organisms committed to memory. So we're not going to spend 19 minutes on this slide here. You can pause the presentation if you want, but you should commit this visual algorithm to memory, which will improve your retention going forward. Bacillus cereus, obviously students know this as the organism that causes diarrhea or vomiting following consumption of fried rice, reheated rice, spores that germinate at high temperatures. But what's really fucking weird is that it can also cause an eye infection, classically post-surgery. Now, the USMLE is not going to just arbitrarily give you an eye infection and then expect you to know it's Bacillus cereus versus Staph aureus, etc. That's not what they're going to do. They'll say a patient had surgery, let's say for cataracts, and that they have an eye infection caused by a gram-positive rod. And you look at the answer choices, you see Staph aureus, wrong fucking answer because that's gram-positive coccus in clusters, okay? You might see E. coli, wrong answer, gram-negative rod. And you might only be left with Bacillus cereus as the gram-positive rod listed. And you're like, that's fucking weird. I thought that caused like diarrhea, vomiting from fried rice, but it's the only gram-positive rod listed, okay? So it can cause eye infections. Bacillus anthracis, obviously cause of anthrax, can be cutaneous or pulmonary. If it's cutaneous, anthrax classically causes a black, painless eschar or ulcer with surrounding edema. Its toxin is known as edema factor. If pulmonary, it can cause hemorrhagic mediastinitis. As I just said, edema factor, you need to know it increases CAMP. And there's some other toxins for USMLE that also increase CAMP. We have ETEC, heat labile toxin, enterotoxigenic E. coli, causes traveler's diarrhea. Cholera toxin also causes profuse watery diarrhea, high volume rice water stools. And Bordetella pertussis, whooping cough. The latter actually inhibits G-alpha I, G protein, leading to an increase in CAMP. The point is, they all increase CAMP, okay? Now, anthrax, it's the only bacterium you need to know that has a protein capsule. When we think about encapsulated organisms, I talked about in the coccus, the gram-positive cocci presentation for splenectomy or sickle cell, right? You need your vaccines against encapsulated organisms. So strep pneumo, Neisseria meningitis, Haemophilus influenza type B, these all have polysaccharide capsules. But anthrax has a poly-D-glutamic acid capsule. The spores contain dipicolinic acid, makes it heat and acid resistant, allows it to the spores to survive on the harsh conditions of the hides of goats. Okay, it can cause wool sorter disease, cutaneous or pulmonary anthrax. Clostridium tetani, the toxin is going to inhibit presynaptic snare protein, decreasing the release of inhibitory neurotransmitters glycine and GABA in the CNS, resulting in increased muscle tone, spastic paralysis, okay? Classic USMLE vignette is going to give you a neonate born at home where the umbilical cord was cut with a kitchen knife, tied with twine, and there's arching of the back, okay? That's from tetany. So high yield, okay? And they want you to know that the toxin enters through the umbilical stump. Quick point about vaccines, vaccines plus post-exposure prophylaxis. You give vaccine for tetanus at 2, 4, 6 months, as well as 12 months, age 4, and then starting in school-age children, 11 or 12, then every 10 years, okay? And for post-exposure prophylaxis, if you've had the vaccine within the past 5 years, you do not need vaccine or IVIG for post-exposure. Okay, neither is necessary. Post-exposure if you've had the tetanus vaccine within the past 5 years. Now, let's say you had the tetanus vaccine between 5 and 10 years ago. If you have a clean wound, such as from a kitchen knife, you do not need any post-exposure treatment at all. If you've had the vaccine within the past 5 to 10 years, and it's a dirty wound, such as a rusty nail in the backyard, then you don't need IVIG, you just need more tetanus vaccine, okay? The only time you give IVIG for post-exposure is if the last vaccine was more than 10 years ago, okay? So you've been due for a vaccine, you didn't have it, and it's a dirty wound, okay? So dirty wound more than 10 years ago, you're going to give vaccine plus IVIG, okay? For a clean wound, you would just give vaccine if it's been more than 10 years ago. Just another random point, don't confuse trismus with tenesmus. Trismus is lockjaw, that can be seen with tetanus. Tenesmus is the intractable feeling of needing to defecate that can occur with dysentery or inflammatory bowel disease. Clostridium botulinum, okay, so botulism, we are going to have inhibition of snare protein similar to with tetanus, but we have decreased release of acetylcholine from presynaptic neurons. So we have flaccid paralysis, okay? So Clostridium botulinum prevents the release of acetylcholine, flaccid paralysis. Tetany prevents the release of GABA-glycine, spastic paralysis. Classic mechanism, high yield, is spores and honey in babies and infants, as in 1 year of age or older. It's going to be preformed toxin in compromised canned goods, classically camping trips. Okay, they might say a 13-year-old went on a camping trip, had canned goods. Okay, so two main presentations for USMLE: floppy baby syndrome, okay, with flaccid paralysis, a floppy head, or if it's an infant or older, they can mention that there are cranial nerve deficits such as dysphagia, dysarthria. There can be Bell palsy. I know I wrote symmetric here, but you can get a Bell palsy, and descending paralysis with potential respiratory compromise. Clostridium difficile, spelled difficile. You need to know it causes pseudomembranous colitis, and it presents with white exudates on colonoscopy that resemble pseudomembranes, apparently. Okay? Now, the presentation will always be some form of antibiotic regimen that a patient received, followed by diarrhea. Now, students tend to memorize pseudomembranous colitis as watery diarrhea. It can absolutely present bloody on USMLE. Okay, there's a 2CK-IM question where they say a patient received antibiotics for 10 days. A younger patient in the 20s now has lower left quadrant cramping with bloody diarrhea. Okay, and Yersinia enterocolitica was the wrong answer. That's a separate discussion. That Yersinia enterocolitica is a gram-negative rod that can cause pseudoappendicitis due to terminal ileitis or mesenteric adenitis. It will be right lower quadrant pain and bloody diarrhea. But Clostridium difficile can cause cramping. It can cause bloody diarrhea. It will be on the left side. It doesn't have to be watery diarrhea. Okay, I've seen antibiotics between 3 and 10 days. Classically, clindamycin, cephalosporins, and beta-lactams. So, mechanisms USMLE likes is ingestion of spores. You might see that as the answer. They give you a simple vignette of C. difficile, and then the answer is just ingestion of spores or bacterial overgrowth. If they list both as answers, choose ingestion of spores, okay? This is another really important detail that students fuck up. You diagnose via stool toxin test, okay? Not stool culture, okay? Stool culture, wrong fucking answer. C. difficile can cause toxic megacolon. They might tell you patient has fever of 104, has low blood pressure. Abdominal x-rays are ordered to look for gas. They might tell you there's a 12 centimeter cecum. I've seen that in a question. And that's toxic megacolon. And if patient is unstable, we often have to do laparotomy. That's more 2CK surgery. In real life, they will give steroids, try to decompress the patient first. But laparotomy is a frequent answer in 2CK for toxic megacolon. Now, the treatment, very important. Oral vancomycin, not metronidazole. It used to be oral metro. There used to be a nice fancy algorithm as to when you used metro versus vancomycin. Now it's just straight to oral vancomycin. Vancomycin has very poor oral bioavailability. So when we give it, let's say for endocarditis with gentamicin, we give it IV. Okay, it's not absorbed well through the GI tract. But in pseudomembranous colitis, that interestingly is a good thing because we want the antibiotic in the bowel, right? So oral vancomycin is what we use for C. difficile to treat, not metro. Now, C. perfringens, okay, it causes both a watery diarrhea as well as gas gangrene. And the USMLE is obsessed with the CO2 gas produced via necrosis, okay? So you can get subcutaneous emphysema, crunching, crackling of the skin. It means air is under the skin, CO2 gas, as I just said. That's going to be C. perfringens. They can even say emphysematous cholecystitis, okay? I didn't mention it in this presentation, but if you have emphysematous cholecystitis, they want C. perfringens as the answer. It means there's gas visualized in the walls of the gallbladder. Necrotizing fasciitis as well, okay? Necrosis along fascial planes, they might say in the question, black color to the skin with the crunching / crepitus. USMLE likes the alpha toxin, and they want you to know it's both a lecithinase and phospholipase. That's how it's referred to, okay? It sounds a little bit pedantic, a little bit nitpicky, but this is one of the organisms they get a little bit more specific for sometimes. So, actually, before I go to the next point, the next organism, one of the ways USMLE will give you C. perfringens in a question is they'll give you classic presentation of gas gangrene, okay? You'll say, okay, easy, C. perfringens. And then they'll say the most likely causal organism can also cause what? And the answer is watery diarrhea. Okay, that's on an offline NBME. Listeria, classic cause of neonatal meningitis, pneumonia, and sepsis after group B strep. So for neonatal infections, if let's say you get a pneumonia in a neonate caused by a gram-positive coccus, answer group B strep. Okay, most common cause of neonatal infections. If they say gram-positive rod, Listeria, gram-negative rod, E. coli. And the mother will acquire it during pregnancy, having eaten soft cheeses, deli meat. And you should know it can cause, a bit of lower yield, that's why I didn't write it in the presentation, but granulomatosis infantiseptica, it's like, ooh, wow, we want to be fancy. Some students get pedantic, okay? But it's another condition that can cause, if a pregnant woman gets Listeria, she can miscarry due to a severe Listeria infection called granulomatosis infantiseptica. Listeria can grow at 4 degrees Celsius. I've seen this in an NBME question. And by the way, it has tumbling motility. I didn't write it on the slide, though. It's a little bit lower yield, but tumbling motility. Facultative intracellular cell-mediated immunity can help clear it. Literature says both CD4 and CD8 can help clear Listeria. USMLE will sometimes just give you what will help notably clearing Listeria. Cell-mediated immunity, humoral immunity. They want cell-mediated immunity for intracellular organisms where Listeria can be. Treat with ampicillin, okay? Just a random factoid. USMLE likes you to know that. Corynebacterium diphtheriae obviously causes diphtheria. Gray membranes in the oropharynx, and it can progress to myocarditis neuropathy. They want you to know the toxin can inhibit elongation factor 2, Pseudomonas, which is a gram-negative rod, can also inhibits elongation factor 2, okay? This might show up in a USMLE question as just merely inhibiting translation. Transcription is DNA to RNA. Translation is RNA to protein, okay? So elongation factor 2, we're talking about protein synthesis. Now look, when we have actually a point I just want to make is that diphtheria, the vaccine, is going to be our DPT, okay? So diphtheria pertussis tetanus, okay? So same as tetanus. Diphtheria is a toxoid, okay? So diphtheria and tetanus are toxoid vaccines. I should just quickly mention that, which means that they're a protein. So gram-positive filamentous rods, not super fucking high yield, but you should just know them real quick. It would be irresponsible if I don't mention them. So Nocardia is weakly acid-fast, actinomyces is not. So when we talk about gram-positive filamentous rods, if they ever show you an image, I could easily do it here, I'm not going to. They'll show you lots of dots Also with branches. You might say, what am I looking at? Is it a fungus? Is it a bacterium? What am I looking at? But they'll tell you in the question, gram-positive filamentous rod, and show you an image that almost looks like a mix between a fungus and a bacterium. Weakly acid-fast, it can cause pulmonary infections similar to TB, okay? It can also cause osteomyelitis and meningitis. SNAP, okay? So sulfonamides for nocardia, actinomyces use penicillin. Actinomyces can cause oropharyngeal infections with yellow sulfur granules, okay? Very buzzy, very easy. Students get really ignited by details like that. And it's not acid-fast, as I just said before. And SNAP, once again. Sulfonamides for nocardia, actinomyces use penicillin. Now, let's just do a few questions here, okay? We could have like 50 questions, but we're just going to do a few. 60-year-old dude, he has long history of type 2 diabetes mellitus, febrile at 103 Fahrenheit. He has black skin around the perineum and scrotum. Physical examination shows subcutaneous crepitus. Q asks, organism responsible for this condition also causes what? So this is actually Fournier gangrene or Fournier gangrene, which is gangrene of the perineum and scrotum, classically seen in male diabetics with very bad glycemic control. And this is Clostridium perfringens, gas gangrene, subcutaneous emphysema, as we said, alpha toxin, phospholipase or lecithinase, also causes watery diarrhea, okay? And also necrotizing fasciitis, but that is actually Fournier gangrene. 8-year-old female, fever 102 Fahrenheit, gray membranes in oropharynx. So this is diphtheria. Q asks for the mechanism of action of the toxin involved. We said that it inhibits elongation factor 2. That's going to be inhibits translation. And Pseudomonas aeruginosa, a gram-negative rod, also inhibits elongation factor 2. 38-year-old female, she has a pet bird, works as a horticulturalist and a postal worker. Horticulturalist, someone who's a gardener, works with plants, often for medicinal purposes. I've seen that in an NBME question, that's why I wrote it here. Has painless black lesion on the forearm with an eschar and surrounding edema. QS for the mechanism of action of the toxin. This is going to be cutaneous anthrax. The toxin will increase CAMP, okay? It's edema factor. I have seen literally pet bird, and you say, how does that relate? It doesn't. It's a distractor. I mean, you could have like, chlamydia psittaci, which is a cause of atypical pneumonia caused by birds. It's not related here. Postal worker, very buzzy for anthrax. I've seen it in a question, but you should just know the toxin increases CAMP. 72-year-old female, cataract surgery 2 days ago. She has very painful eye, fever 102, intravitreous antibiotics administered. Culture shows gram-positive rod. What's the most likely causal organism? We said that this is going to be Bacillus cereus, same organism that causes watery diarrhea or vomiting 1 to 6 hours after eating reheated rice or fried rice. Neonate pneumonia caused by gram-positive rod, most likely causal organism was most likely acquired by the mother. How? So we said neonatal infections can be group B strep, gram-positive coccus. It can be gram-positive rod, Listeria, which is the answer here, or E. coli, gram-negative rod. So the mother is going to acquire Listeria by eating soft cheeses, deli meat while pregnant. 6-month-old boy, severe hypotonia. Diet consists of breast milk plus occasional supplemented formula mixed with honey. What's the mechanism of action of the toxin here? So we are going to have Clostridium botulinum, and this is acquired via spores in honey. Botulin toxin will prevent the presynaptic release of acetylcholine, okay? Not to be confused with tetanus, which prevents the presynaptic release of GABA and glycine. And so we said spores in honey for babies, and then infants or older, it's going to be preformed toxin in canned goods, compromised canned goods, such as camping trips. And we said that we can get cranial nerve palsies with descending paralysis and respiratory compromise, okay? Or just floppy baby syndrome. 50-year-old dude, HIV positive, painful sinus tract within oral cavity, gram stain shows yellow granules. And our, okay, so what's the most likely organism of treatment? It would be a gram-positive filamentous rod, and this is going to be actinomyces. So that's our classic sinus tracts. And we said SNAP, okay? So sulfonamides for nocardia, actinomyces, use penicillin. So penicillin in this case. And then I just threw the algorithms again at the end. You should just commit these to memory. Will help with your retention overall. And that's it for this fucking presentation. Okay, so gram-positive rods, you know the deal. I'm going to continue making more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.